Good afternoon. This is Joanne Spetz. I'm the director of the Philip R. Lee Institute for Health Policy Studies, and we are very excited to have our inaugural Health Policy Grand Rounds. Our guest today is Lisa Simpson. Lisa is the President and Chief Executive Officer of AcademyHealth, which is the major health services research and policy professional association in the United States. She's had this role since 2011 and is a health policy researcher and pediatrician. She has an illustrious biography that I will place in the chat, the link for it, for you to read more about her background. But one of the most important components of her background is that she did her postdoctoral fellowship in health services research and policy at UCSF at the Institute for Health Policy Studies. She's going to speak today about the future of health services research. Please put your questions in the Q&A box, and I will hand it over to Lisa now.
Great. Thank you very much, Joanne. And thank you for inviting me. It's really a delight to have any opportunity to come back to my old stomping ground, even if I'm only joining you virtually. I am going to share my screen now. Let's see if that works. Wonderful. So I'm delighted that the Institute is launching this Grand Rounds series and to be your inaugural speaker. So I've got remarks that I've prepared for about 30 minutes, and then Joanne and I are going to kind of have a fireside chat with all of you and answer questions you may have had coming into today's conversation or that are prompted by my remarks. So as you can see, my title is focusing on the future of health services research, innovation, improvement, and equity, three important dimensions that I will touch on. There are four parts to my remarks. First, I want you to understand where I'm coming from. So I'll talk about a bit about my perspective. I'll talk briefly about the past and present of health services research to really ground everybody in what we're talking about. And then I want to get into sort of more of the future orientation, which is a framework to shift the paradigm of health services research. And to that end, three areas of critical focus for AcademyHealth. So let's warm us up, and we're going to ask you about your primary discipline. Where are you coming from to this discussion of health services research? So please fill that out, and we're going to give you a few minutes to answer that. And let's end the polling now and share the results. So it looks like most of you, the most common response, almost 40%, is health services research. So yay, you're part of my tribe. And some of you come from my first tribe, which is medicine, and so great to see nursing and pharmacy represented, and many, many others. So in the chat, we'll look at it later, but why don't you just share in the chat with your colleagues what we missed? What is your other discipline? So now we've got those Zoom polling muscles warmed up. Let's keep going. So I mentioned I would talk about perspectives. So I want to tell you about AcademyHealth. Usually if we would be in person, I would ask for a show of hands. How many of you have ever heard of AcademyHealth? But I will just tell you who we are. We are, as Joanne said, the National Organization for Health Services Research, and our mission is to improve health and healthcare for all by advancing evidence to inform policy and practice. And so you can see that evidence is what I like to call is our North Star. And before the pandemic, we were focusing on four goals here on the left side that our board of directors had worked with us to establish at the end of 2019. During the pandemic, we then worked with our board of directors to really focus our activities and meet this moment and really help our field of health services research step up its game and be part of the response to the experiences of this nation in grappling with the pandemic, economic disruption, and racism in all of its forms. And so you'll see we established three cross-cutting priorities: science innovation, health systems improvement, diversity, equity, and inclusion. At the same time, we had previously, as part of our strategic plan, established these core values. And the reason I include them today is that the pandemic and this living through this last year has really reinforced for me as a leader the importance of really leaning into your values, values of diversity and inclusion, values of collaboration and community, and trust in science and integrity. So I wanted to share those with you, as they are really my touch points as I do my work. In terms of what we do at Academy Health, we have a lot of different programs, many more than you may be aware of. On this right-hand side, you see our annual conferences. I hope all of you submitted an abstract to the annual research meeting, or maybe we'll meet the deadline for the late breakers, which is March 31st. But we have many other activities, scholarships, fellowships, learning communities, and methods and data to really work on all the aspects that the field needs. How do I come? The second perspective I want to touch on is my personal journey. So as I alluded to earlier, and Joanne mentioned, I am a pediatrician. I'm board certified in pediatrics, but I also trained in preventive medicine. And early in my career, I pivoted to public health and worked in state public health, and then came back to train at IHPS with a nurse postdoc, and really to understand the evidence that informed policymaking at the state and federal level. And so my whole career has been around either shaping health services research as a federal funder, doing research myself in academic institutions, or as I do now, to try to elevate and advance the field. And along the way, this is a time where we've talked a lot about the various identities that we bring to ourselves as professionals in our careers. And so, of course, my name, hopefully you got the reference to Lisa Simpson. And yes, I do have a sister named Maggie, believe it or not, but no brothers. And depending on my career stage, I have been all of these, very much an outsider growing up overseas, an international medical graduate, and I won't read all of these, but I think the point when I speak to an academically based audience is that we are many things over the course of our careers. And so that is fine. And that is actually exciting. So that I've had the privilege of being able to work to improve healthcare in many different ways. So let's focus on health services research. A brief review. We're going back to a poll so I can see where you guys are on your continuum now, hopefully since you're 39% health services research. So yes, given the audience, delighted to see that you're very familiar with health services research. So that means I'm going to jump over the next two slides very quickly. And for the other third who are joining us today, I hope you come away with your CME question being able to say, now you better understand what this field is. Thanks so much. So now let's move on to the official view of health services research. And I always go back to the core definition. And for the clinicians in the group, I like to say that, I have to have very good lung capacity to get through this whole definition in one breath, so I am not going to read it. And the reality is that health services research is about solving problems. It answers questions that leaders have. What works in healthcare? What works in policy? How well does it work? It's not just an up and down yes or no, but what's the effect size of this intervention? What's the effect size on whom? Whether it's a policy intervention or a care intervention. And under what circumstances, for those of you who may be doing health services research subset on dissemination implementation research, you know that context is everything. So how do we understand the circumstances that affect implementation? Clearly, for policy and leaders in health systems, how much it costs is critical. And increasingly, as we see costs being shared with individuals and families, that is also a growing concern for families. So we need to answer the cost question. And then once we know what a particular intervention or policy in one setting has as an impact, how do we scale and sustain it? And in the 1990s, which is really when I sort of came of age in this field, my training at UCSF was 1991 to 1990. No, was it? Yeah, 91 to 93. The dominant frame was really this CQA. That's what I learned about, was cost, quality, and access. And more recent, and so I want to come back to that frame and how it's evolved, but I want to ground us in, well, how much funding is there for health services research? Because I would imagine many of you are seeking funding. and competing for funding. And so while we never feel that there's enough funding for our field, and Academy Health works very hard to advocate for the field, you'll see that actually in this analysis that was funded in HSR, the journal HSR, a couple years ago, we've seen an increase in federal funding. But most of that is actually, if you go to the right, you'll see that NIH is the dominant funder. But as much as there has been growth, you'll see it remains a small portion of the annual NIH budget. How has the types of health services research evolved? Well, this is from the most recent report that if you haven't looked at it, it was published in 2020 by RAND at the request of Congress who wanted to know about the impact of health services research and the nature of health services research. And so this framework that they included in the report, I think really exemplifies how we've gone from just a cost, quality, access view to include a very strong dimension of equity in health services research. Now, here are two very busy slides, and my slides will be available, so I'm not going to read them, but the point here is that this report also included a number of gaps in health services research. So unless you wonder what should you study, this report is replete with information about gaps in research. And so you'll see issues around the full range of populations, again, distributional impact, the issues around implementation, communicating our results effectively, improving care, digital health, and healthcare related data. So this is both for health services research and primary care research. In addition, it went on to drill down. And again, I've only highlighted those areas which are about actions, how health services research can help improve care. I think in the first several decades of the field, and you can argue with me during the Q&A, we were very good at observational sort of epi of what happened in healthcare. We documented disparities, we documented access problems, we documented what is happening in care delivery. And now we're really moving to intervention and studying the effectiveness of those interventions. And when you think about the impact, Rand also identified multiple levels. And I really encourage all of you to think about the impact of the work you're having. Who do you want it to influence? How do you want it to get used? Define that when you start your question. This is not, while it's very much driven by intellectual curiosity, it is also informed by what the users of research need, those who are in positions to change or influence care. Finally, on the impact of health services research, I would commend this report to you, not just because I'm one of the editors, but I think it's an important compilation. And even if you only read the executive summary, it is an important sort of guidepost for where the field needs to go in the future. And again, this report underscored the impact on healthcare policy and the way that health systems operate. And you'll see the bolded areas. But it actually underscored the importance to focus on a point I've just made, which is translation, implementation, communication, and really deepening the capacity to transform health systems and health improvement. So now let's go to what our next poll to keep you paying attention. And if you could launch the poll, which of these do you think holds the most potential going forward for advancing the field of health services research? All right, so addressing social determinants. Yes, I think that is so important as we think about the equity dimension. That was the #1 response. Funding and relevance came in second. So thank you. Yes, I agree. So let's keep going. What is this paradigm shift I alluded to? How do we increase our relevance and address social determinants? And hopefully, if we are more relevant and doing good work, increase funding for the work that we do. So we began this project called the Paradigm Project a couple of years ago with support from the Robert Johnson Foundation. And why did we embark on this? It's a pretty important and broad and ambitious agenda, but really grappling with the relevance and timeliness of health services research. And this was pre-pandemic. And at the time, the reason we began this work is that we were really seeing the broader societal trends that you have all experienced, which create both opportunities for us, and an imperative for change. And so some of these are listed here: the demand for greater diversity, the expectations for transparency. Of course, the first one, the fourth industrial revolution, and you are close to where that is a hotbed of data and technology innovation, and our expectations for social impact, that this compact that we have as academic, that you have, I'm not an academic anymore, as an academic institution, to have an impact in society and contribute to the betterment of society. And so in the Paradigm Project, together with a steering council and a learning community, we have been working on 6 thematic challenges. What is the cohesive vision and shared purpose today of health services research? How do we ask the right questions? And to ask those questions, how do we make sure we're involving the right people and partners? How are we applying the right data and methods? And once we have our findings, how are we translating that using the right messengers and messages so that it can be applied? And then what are the incentives that allow us to both do our work, but also have it applied? And through the Paradigm Project, we're using multiple modes of influence and change. We are using human-centered design. And to our knowledge, when we started this, we were the first field of research that was using human-centered design as a core methodology. And so very new to me in approaching these questions. We've been doing also expert meetings, which is a more familiar tool and approach, thought leadership, as well as a number of commissioned papers, and they're available on our website and more are coming. To give you a specific example, one of the innovations that was developed through one of our design teams and human-centered design is this incubator, which is fueling collaboration and implementation. And so the idea here is, while historically academics and researchers have thought of their research question and then seek out a partner, this actually sort of is intended to change the power and relationship dynamic and have the community-based organization bring their identified priorities and needs to the researcher. And we're also partnering them with a provider or health system that serves that community to come together to understand the challenge by reviewing the literature, to define a work plan, and then to actually try to address the challenge, and then to create this online repository of what has been learned in trying to apply an evidence-based intervention to addressing the community's needs. So that's a quick review of a very complex and large paradigm shifting project that we're involved with. And so these are the same 6 areas we're working on. And now I'd like to launch the next poll to see which of you do you think are the most important for us to focus on as a field. All right, thank you. So we see that asking the right questions, wonderful. Yes, we have to ask those. And I'm really actually heartened to see that that is very close to also the right people. If we don't have the right team in the room coming together to formulate the questions, then our research design, our data, our approach may miss the mark in then coming up with relevant and timely answers. So thank you. So now my final segment of my talk before we turn to the question and answers is focused on 3 specific priorities that Academy Health is pursuing that also imbue the Paradigm Project, but are really, as I said at the beginning, are imperative to address as a field and at Academy Health in the coming years, given the world that we live in today. So first is science innovation. We have, not prior to the pandemic, we again saw the opportunity of leveraging data from all sorts of news sources. No longer do we need to rely on just national surveys like MAPS or NHIS or et cetera, or secondary claims data sets, which I cut my teeth on, whether that's Medicare or finally cleaned up Medicaid data. And then the pandemic came, and we saw all kinds of other ways that global collaboration and rapidity really stepped up, particularly in the clinical space. And so as we think about science innovation, we are looking at every step in the research life cycle. We've already talked about the questions, but one of the areas we're working hard on is how do we do patient and stakeholder engagement well? We actually have been working with PCORI for a number of years on this. We coordinate the Patient-Driven Research Networks Coordinating Center. We also serve as the engagement core for the PCORNet engagement group. And we are also the behind the scenes sort of back end curators of the PCORI Engagement Explorer. That's a wonderful resource on the PCORI website. If you're not familiar with it, I would take you there. It's actively curated. We add new research to it all the time. So you can learn from, as we're all learning about not just patient engagement, but how do you engage stakeholders in all the different settings that we hope to work with. We're looking at how funding is allocated and looking globally for innovations from other countries for how to allocate resources. We released a report on this from Susan Guthrie last year. She's updating this now in the time of COVID, and an updated report will be released shortly. We just had an expert meeting on looking at complex data, AI, all these new methods that we are trying to incorporate into health services, into our toolkit or toolbox. So we're looking at academic incentives, incentives to use research, et cetera. So if you think about all of these steps in the pipeline of how research is done, what do you think is the most important for us to innovate on? Again, this is the innovation angle. What needs to change? What would you like to see work differently? So if we could launch the poll now. Okay, patient and stakeholder engagement. Okay, very good. Yes, I think that honing our skills as researchers is a really important way. And we're certainly looking at innovative ways to do that as well. So thank you for that feedback. So the second area in our 3 priorities is advancing diversity, equity, and inclusion. And we chose those terms very specifically. Language is critically important here. And we've been working with Dr. Margot Edmonds, who actually I met at the Institute. She and I get to work together again. She is one of our vice presidents. She joined us in 2012. And she has been leading our Center for Diversity, Inclusion, and Minority Engagement since 2015, when we established it with board investment. And when we established DEI as a cross-cutting priority, she is now our strategic lead at AcademyHealth to execute on this. And this is a framework that she developed that's specific to AcademyHealth. So how do we model DEI in all its forms by assessing ourselves and making sure that all of our actions follow those values? How do we lead? So how do we work with our members, all of you, our partners? What does this mean in terms of who gets to be involved in our leadership committees, on our board of directors, in our conferences? Who gets, so to speak, voice to be on the platforms that we have access to and can curate? And then through our supportive education and our education council, the collection of syllabi on racism and equity topics. And then how do we influence the field? How do we work? Because we are a small organization. And so we work with and through other organizations. So right now we're working with an external advisory group to deliver a report that will be presented to the board of directors in June and to the field at the annual research meeting in a town hall format with their recommendations of what else we should be doing as a field of health services research. And so I'm really looking forward to that wonderful group. Their names are listed on our website in a blog that Margot wrote. So you can look there for more information. But one of the specific activities we're working on is this work around bias and data analytics. And a subset of that is we are developing a workshop on anti-racist research methods that will be held later this spring. So again, we can influence, we can help, and we're very much looking to partner. We also worked with UCLA last summer with students of Ninez Ponce and Michelle Coe they developed and fielded a survey at the annual research meeting on the culture of health services research and the spirit of inclusion and diversity within our health services research community in America. It's a US-based survey. There has been more recently, not more recently, also a global survey of of that same topic done by the Wellcome Trust in the UK. So there's actually quite a lot of global attention to the culture of research. And so we're also looking at that. So I want to ask your question now for your input. What do you see as our biggest challenges in achieving genuine diversity, equity, and inclusion in the field of health services research? So if we can launch the poll, these again are longer response options. So I want to make sure you have enough time to digest them. And here you can select all that apply. But it would be easier for me if you were picky, so we could see what rises to the top. But if everything is important, obviously we wanted this to be all that apply. So you see here that lack of recruitment of underrepresented populations comes as number one. Number two is the culture of systemic racism in an academic institution. And next is the need for more diverse leadership in academic institutions. These are all critically important. And one of the conversations that we have been having at AcademyHealth and with our external advisory group and with our board of directors is specifically on this issue of systemic racism, not just in academic institutions, but in our field. And so I think I'm really not surprised to see this come up as a very important priority for this group. And I would love to continue this conversation with you as we work on this. And so, if you hadn't already planned to come to AcademyHealth's annual research meeting, virtually, of course, this June, please think about that and join our town hall meeting where the results of the report and the recommendations from this external advisory group will be presented. The final area of those three priority areas that I want to talk about is health systems improvement, resilience, and capacity. Now, this is an enormous topic. As much as the others are enormous as well, this one, we have sort of quite a lot of breadth within AcademyHealth's membership on this. And so, first of all, we have our interest groups. Joanne is a very active member of the workforce interest group. I hope many of you are active in one of these or other interest groups. I just pulled out, we have 19 of them. So I just pulled out 5 that are, jumped out as very relevant to how do we generate the evidence base for improvement in health systems that address these important dimensions. We are also working specifically with colleagues at various Kaiser Permanente and other settings about embedded research, about those of us who choose to pursue a career within a delivery system, and how do we support their career trajectories and their work. And then finally, we're doing quite a bit on professional development. And we have recently started working with the VA on their Learning Health Systems Fellowship, and we'll be serving as their coordinator for the next round of those fellowships. So again, we have breadth and depth in pushing this health systems improvement agenda, thanks to so many of our members who are engaged. So now I want to ask a question about health systems improvement. So what do you see as the biggest barrier to the implementation of truly evidence-based healthcare delivery? So let's launch that poll. This is our last poll. Yes, misaligned financial incentives for health systems. Yes, this issue of population health, value, moving beyond fee-for-service, that is a very deep problem. And many of you, 3/4 of you, picked that as one of the issues. And I'm quickly scanning resistance to change, and then lack of leadership knowledge on how to implement. Absolutely. This is fascinating. Thank you for your responses, and also the infrastructure to support change. And as hard as this was pre-pandemic, it is sometimes, even though we've been able to institute change with telehealth, health, and pivot more quickly than anybody saw possible. So I think we've seen a proof of concept of what really is possible when necessary. let's hope that more change does not require that level of urgency to accomplish truly evidence-based healthcare delivery. So my final reflections before we open it up for Q&A is, sort of more personal, like how do I make sense of this journey that I'm on? It's not over yet. I've been at it for a little while, as you can tell from when I did my postdoc at CSF. But I think that health services research is really a dynamic, exciting field that I believe has shown it can significantly improve care, not just care delivery, but also health. That how important it is to learn what you love. So, I came to health services research from clinical care, and that's for questions and frustrations, but you may come to it from a different perspective. Bring that passion and that curiosity to the field, because that's what will sustain you through some of the hurdles and normal career bumps and hiccups that we all experience. I personally was very drawn to gaining new knowledge as well as to wanting to make things better. And if you have that bias towards action, this is the field for you. Frustration. You've got to have a certain degree of dissatisfaction with the status quo if we really want to improve health and healthcare for all. And health services research is a wonderful place to do that. And then finally, as I've reflected over the years, it's important to understand the underlying patterns in the choice that you make. Because if you just looked at my job titles over the years, you'd wonder, well, why did she do that? I think I've learned that I always maintained, for example, an academic appointment when I was in government, when I was in state government, and now that I'm in a nonprofit, I still have an adjunct appointment at GW. So achieving and maintaining credibility is through science, I think, is critical. Building bridges is really important. Many of you chose that, selected and gave us the feedback about the importance of getting the right people in the room and the right partners. That's about bridge building. And then the final reflection is a bit more personal, which is, as you grow your career, know when you're ready for the next step. Health services research and healthcare offers lots of leadership opportunities, so don't be afraid to seize those. So now, back over to you, Joanne, and to all of you to engage in a conversation.
Great, thank you, Lisa. We are taking questions in the Q&A portion, and Lisa, if you can end your screen share, then we will all see you better. Thank you. So a question came in on your slide where you were looking at, or you asked the question about the biggest challenges, looking at the wrong question, where we have had the most change or readiness for change in the research life cycle for health services research. And one of the options for response was incentives and rewards. And one of the attendees was curious what kinds of things you had in mind with incentives and rewards.
Yes, thank you. And I will answer this first from an academic institution's perspective and my time in academic institutions and my service on, your external advisory group and others. So academic incentives are very important. In other words, grant funding and publications, and as opposed to impact, and getting credit for the hard work of partnership with communities, with health systems, and working on dissemination and implementation. Not research on implementation, not research on dissemination, but actually doing that last mile, helping to get your evidence into practice. Now, not every single finding should be implemented. That's a whole other conversation. It's what's right for implementation. And so that misalignment between what we as researchers are incentivized to spend our time doing and how to get impact, we often hear that there's that misalignment there. That's one dimension of incentives. We talked about the incentives that health systems have. They live under a different set of incentives. And so this conversation, one of the papers we commissioned and we just published on our website several weeks ago is by Jonathan Grant, who's at King's College in London, but prior to that he was at Rand, and he's been very involved with the British research excellence framework to hold universities, hold back some money linked to impact. They've got to show societal impact as part of their funding. And we haven't gone that far in this country. And so he shows a whole series of sort of provocations of what might we think differently about incentives in research to drive for more impact.
Great, thank you. Anil McComb, who is one of our affiliated faculty, asked a great question. He asked he said that COVID has shown a light on the US's woeful infrastructure to do pragmatic randomized controlled trials. Do you think that the CoreNet will ever be able to launch timely, pragmatic, real-world trials like the Recovery Network in the UK, which was able to do this for COVID-19?
Wow, that's a pointed question. I have been somewhat disappointed at the speed at which funders have, at their agility, their lack of agility at launching and sustaining not just pragmatic clinical trials related to COVID, but actually more health services research about the impact. This is just from one dimension, the policy impact. Every state, we are a federalism country. We leave a lot of decisions to states, and we did that even more so during the first year of the pandemic. And so we ended up with, a kind word would be 50 natural experiments. However, we did not build any capacity for monitoring, studying, or evaluating these natural experiments to learn what state approaches, which decisions, which deployments, which investments worked and which ones did not. And so I think we really, I've been pretty vocal about how disappointed I have been about funders' ability to respond to that opportunity. Not enough to just provide COVID supplements. It is not enough to do another traditional NIH round of funding grants for traditional research. This was a national emergency. It still is. So I hope that we can do more. And I had not heard about this UK network. I hope NIH is watching. I will give NCATS credit for launching the NC3. If you're not familiar with a national cohort collaborative, there's 3 C's. I can't remember NC3. One of my staff I see are posting in the blog with resources. They will post a link. But that was a very responsive initiative to build a data set on which we can do COVID-related research.
Great. I know that there are other efforts that have been underway to build databases. The priority registry that is housed at UCSF, as I understand it, is trying to get information about maternal health and people who experienced pregnancy during the COVID pandemic and who were infected. So there's a lot of opportunities there. I think I agree that there's a challenge of bringing together all this information from 50 different states that all did different things, and the data sources are so disparate. One of the anonymous attendees asked about what you think are the barriers that most impede health services research's ability to engage community partners and to ask new kinds of questions going forward.
So I would like to say it's a systemic problem. First of all, it is, first of all, not, CBPR has been around for, Barbara Israel, gosh, I'm trying to remember her name. I met her at UCSF, who's a leader in CBPR, anyway, in that region. So this is not new. Some institutions have been doing community-based participatory research for years. It has not been adequately funded or incentivized or recognized. So again, we like to talk about behavioral economics in terms of how to change the behavior of physicians and clinicians and health systems. Well, researchers respond to behavioral incentives as well. And so I think we really need to think about first, can you get funded to do this work? Second is the skills to do it. It is, I've heard, I will anonymize this anecdote, but that a group tried to bring in various patient groups of the type of community they serve, and they were well trained, the patient groups. The researchers had not been prepared to deal with input from the patients on their research priorities. So there's a skill set about doing this kind of engaged research. And some of that can be found in that, certainly point you towards the explorer. And so, this is not just new entrance to the field. Those of us old dogs who've been at this for a while definitely need to learn new tricks about how to do this better. So I think that there is more opportunity now. And I think one of the biggest changes in our field is really because of PCORI. That has really pushed the patient stakeholder engagement science and opportunity and responsibility. But that needs to be much more the default and not the exception.
Yeah, I think that there are some agencies that are moving forward in that direction, more towards incentivizing that patient-centered research or encouraging or requiring it. There was a National Institute on Aging Summit on dementia care that was originally going to be last year in the spring and became a virtual summit later. It was still really quite impressive. And for the panel that I was involved in, we were told that every panel was going to have a kind of consumer representative, patient representative, stakeholder representative, at least one person that fell into that category as a panelist. So in our section, which was focusing on dementia care, kind of health services and workforce and financing, there was also a presenter who herself is living with dementia and was very articulate about the kinds of research that she needs or she perceives as needed to help respect her and bring her life forward, and understand that she is totally able to be a participant in research and has a very strong view about what might be important. So it was nice to see that important thing and perspective in the National Institute on Aging's work. So I think it's moving beyond PCORI, but I agree, PCORI has been the key to really launching a lot of that or pushing it forward. There was a great observation also that came through the Q&A that there also can be a lot learned from patient advocates and home health aides who are in the front lines and are not necessarily, say, the patients in thinking about patient and community-based research, but they are key members of the community for healthcare.
And if I could comment on that, Joanne, yes, I absolutely agree. And in fact, we all have to do a better job, Academy Health included, on engaging patients. And so we started several years ago by providing patient scholarships at one of our events, the Health Data Palooza. And many of those who received at the time, because these were in-person meetings, they were travel scholarships and registration scholarship to attend the event. And many were patient advocates. We've now expanded those scholarships to include the NIH, the conference we do in partnership with the NIH on dissemination and implementation research. And we are, now developing a whole category of patient membership in Academy Health. Again, elevating that this is part of the community of health services research, part of the family, not an outsider. So, we are always looking for more ways that we can also sort of walk the walk and be diverse and inclusive of this dimension as well.
Yes. I'd like to, so there's one item here that's really more of a comment, and I'm going to actually let it be anonymous for reasons that'll be obvious. Somebody basically asked that it would be very useful to have some updated lists of funding sources that do health services research, updated from the paper a few years ago, because some deans, especially in health sciences campuses, believe that only NIH support is viewed as the highest level of university recognition. And those of us who do health services research know that many NIH branches don't really fund health services research, and that other organizations like AHRQ, PCORI, HRSA, and so on are very important funders and also very influential in terms of funding research that gets heard and influences practice and policy. So I don't know if you want to add any thoughts to that, but I think it was a great comment. No,
thank you for that comment. And we actually, that chart that I showed, as was mentioned, is from an article in that was based on 2016 data. So it is now very dated. But we actually do track annually the amount of money that that is funded by each agency. We just don't have it in detail and all that, but we can certainly provide that and it's a good thought. We can send that out to all our members, let them know it's available. So because we keep track of that every year. And I think the
Great,
other
that
point
would be
to
great.
make, though, is that while I completely agree with the comment that these other funding sources are critically important as well, NIH does fund the bulk of federally funded health services research. It's still, you saw that pie chart. And so it's not every institute, it's not every place, as you said. Some are more receptive, like NIA has been traditionally much more receptive. So happy to provide that.
Yeah. Yeah, I think there's a broader educational mission which this Grand Rounds is intended to help fill in making sure that leadership in healthcare campuses, health sciences campuses, are aware of the breadth of health services research. We're very fortunate at UCSF to have a long history of it and to have deans across all 4 of our schools that are very supportive of it. But not every institution has had that historical benefit. So Claire Brindis, our immediate past director and distinguished professor emeritus, thanked you for your talk and asked, what advice would you give to the next generation of health services researchers in terms of the disciplines, methods, and content areas that need to be prioritized?
Great question. And of course, Claire is not only everything you just said about her, but she's a member of my board of directors. So I benefit from her wisdom very directly now. I would say that we need all those methods. I am a firm believer in the mixed methods, multidisciplinary approach to our field. I was trained quantitatively. I don't have much formal qualitative research training, but I really, it's one thing to know what the answer is. It's another thing to understand why you got that answer. So I think you can't be an expert at everything. And I would encourage you to look at the core competencies for health services research that were developed as part of that and published in that same issue of health services research. And they're all there. So we can't be expert at all those core competencies, but you need to have a knowledge of those. And the other point is, and therefore you need to partner with people with deep expertise in these other methods to complement you. So learning to do that partnership research. When I was, 8 years as a full professor, I always worked with a health economist because as a clinician, I'm not trained in social sciences, and that blend of theory, theoretical frameworks, and metrics was really helpful to me as a clinician health services researcher. There was another part of it was the methods and what was the other part of that question I wanted to speak to? There's Claire. And the content areas, well, absolutely. Well, in terms of disciplines, you can come from any discipline and be a successful health services researcher. I truly believe that. And the boundaries around our field are blurring. You just need to commit to developing the tools and skills of our field. And if you're committed to answering the questions that matter, you're welcome to come. Please be part of us. And the content areas, personally, this is not Academy Health saying which one it should be. I think this country must address equity. And as part of addressing equity, it has to grapple with the issues of race in our country. And I'll go back to Martin Luther King and the most, to paraphrase him, but about the injustice of disparities in health. Again, a terrible paraphrase, but we must do our part as a field. And so I would encourage folks to look to that content area.
So there's one last question, and then I think our time today is sadly going to be up. Catherine Phillips, who is an affiliate of IHPS and is in the School of Pharmacy, observed that NIH funding has been increasing, but of course there are concerns that the economic toll of the pandemic could lead to some cuts. Do you think that health services research is going to fare well in the coming years in NIH funding?
So great question, Catherine. Great to see you. Thank you for attending. It's all relative, okay? NIH has a very deep support in Congress that is bipartisan and longstanding. And while I agree that after the next couple of this year or whatever of spending increases, which are in response to the economic situation and the pandemic, Will we see a contraction potentially? Yes, potentially, particularly if the if other factors continue and there's not a rebound in the economy. But of all the places where cutting is less likely, that would be NIH. Now the question is then, within NIH, will it be deprioritized? And that's where the role of all of us comes in as voices and champions for health services research to hold the various institutes and centers, not just the leadership, accountable for this funding. And I would say that there is increasing understanding that health research, biomedical research, needs to include that last mile of actually getting those cures to care. And so that's a growing chorus. So I wish I could say no problem. It's never no problem when it's money in Washington. But I think that health services research will perhaps fare better than some other investments because at least that services research at NIH. I have not answered other parts of research funding.
Well, I think President Biden's executive order on advancing racial equity through support for underserved communities through the federal government aligns very well with your personal charge to us to think about equity, diversity, and keeping that in mind as one of the preeminent areas where we can contribute to making a better health system in the United States. So I think that is a particular area where your charge to us to also advocate for health services research is an area where we can help draw the linkage between the importance for health services research in understanding where our health system is failing to achieve equity and how we can do better. So I think I see a glimmer of hope there, although I tend to be the optimist, and I think you are too. Thank you so much for being here, Lisa. We really appreciate your time today, and I'm seeing some great session comments and thank yous showing up in the chat as well. We have recorded this session, so we will be posting it and sharing it. Anybody who hasn't had the opportunity to attend, please tell your friends and colleagues that they can learn a lot by joining us. Thanks so much, Lisa.
Thank you, Joanne, for your leadership.